Well, hello, everyone. Good afternoon. For those that are just joining, this is Sharon Byron from TruCode, and I'd like to welcome you to today's webinar, CPT Spinal Fusion, which is presented by Vanessa Yeomans from Yes HIM Consulting. I'm also joined by my colleague Karen Scott, TruCode's Director of Education and Training. So hopefully by now you're all familiar with TruCode and our awesome encoder, but for those of you who may not be, I wanted to just take a minute and tell you a little bit about us. So TruCode develops encoder technology that's used by many hospitals, consulting firms, payers. We have a unique approach to coding that has been proven to increase coding accuracy and productivity, and we have a workflow that coders love. We work with most EHR vendors, so if you're interested in learning more, we would love for you to join us at an upcoming web demonstration, and you can register for that through our website. And we promise you won't be disappointed in what you see. So before I introduce Vanessa, I just wanted to review a few housekeeping items to ensure a successful webinar. First, all webinar attendees are in listen-only mode, so that means you'll need to use your control panel to communicate. You can find this on the right-hand side of your screen. You can minimize it to see the screen better by collapsing or expanding it with that little red box with the arrow in it. If you want to ask a question, you can do that in the questions section of the control panel, and that's towards the bottom. To ask a question, you can just click on that little plus button. It will open up a text box. You can type your question into the box. At the end of the webinar, we'll try to answer as many questions as possible, but if we don't get to your question, still submit it because we'll pass those on to Vanessa, and she has offered to respond to them in writing, and then we'll send those out to folks that ask them. So questions are encouraged. I also mentioned earlier, but want to point out again that handouts are available in the handout section of the control panel, and those were also emailed in a reminder email earlier today. So hopefully you had a chance to grab those. And then lastly, and most importantly, we want to make sure you get your CEU. So tomorrow morning, we'll be sending out an email to everybody who attended. That will contain a link to a brief webinar evaluation. So once you submit that evaluation, you will be able to download your CEU certificate. So that's coming tomorrow. If you have any questions or problems, feel free to reach out to me, and you can do that just by replying to any of the emails, any of the webinar emails you've received. Those will all go to me. So let me know if you have any issues. Okay, so as we get started, we wanted to get a better sense of our audience and your experience. So we thought we would start with a quick poll. So I'm going to launch the poll, and we would love to know how often do you work with CPT Spinal Fusion code? So if you could answer one of those choices, we'll give you a couple seconds to do that, and then I will share the results. Okay, let's see. Whoops. All right, so you can see it looks like most people say they sometimes work with these codes, and 22% often work with them. So that's great. That's helpful, I think, for Vanessa as we head into this presentation. Thanks everyone for participating. Now I'd like to introduce you to today's presenter. You know what? I'm going to just close this. There we go. All right, so now I'd like to introduce you to today's presenter, Vanessa Yeomans. Vanessa holds a Bachelor of Science degree in mathematics from St. John's University and a master's degree from New York University. She's currently the Director of Outpatient and Pro-Fee Services at Yes HIM Consulting. She has previous experience as an education and data analysis subject matter expert. She holds the Registered Health Information Administrator, Certified Coding Specialist, Certified Professional Coder, and a HEMA-approved ICD-10 CM PCS trainer credentials. She served as Secretary for the Gulf Coast Health Information Management Association from 2019 to 2020, and she's currently serving as the Coding Roundtable Committee Chair for the Florida HIMA. So Vanessa, thank you so much for taking the time to present for us today, and I'm going to hand it over to you.
Okay, thank you so much, Sharon, for that wonderful introduction. I first of all just want to thank TruCode so much for this opportunity to speak today on the very fascinating and sometimes confusing world of CPT and spinal fusion. Again, my name is Vanessa Yeomans, and I'm the Director of Outpatient and Prophy Services at Yes HIM Consulting. Here at Yes, we do have our own education portal that we have on a website that you can find. If you go directly to our website, we have a separate website where you can log in and take education and earn CEUs directly online. And this is a series. We actually had a lot of discussions with people in the industry, and we heard a lot, hey, I always want to take continuing education. I need to get my CEUs, but you know what? I don't always have an hour to dedicate to a full 1 hour webinar. Is there anything that you all can do for that? And we listened, and what we decided to do was to create a series called Refresh with Yes. And what we do is we break up hot topics, and spinal fusions is definitely one of those hot topics. We break those hot topics into bite-sized portions. They are usually 10 to 15 minutes. And so if you only have 10 or 15 minutes to spare, maybe you're on a quick break or a quick lunch break, you can watch that just 10 or 15 minute portion and build all the way through a topic. And at the end of it, you would earn a CEU. So what I did is I took our 4-part series on spinal fusions, and I combined it into one 1 hour webinar for you all. And it's really 4 sections that we have from our Refresh with Yes. So here at Yes, we have a disclaimer, but you can of course read that later. So our webinar objectives are as follows. And like I said, this is kind of taken from a 4-part series on our Refresh with Yes program. So we have 4 of the sections here. First, we're going to go over our spinal anatomy and disease processes. And this may be a little bit of a review, but you know what? Sometimes the terminology within these op reports can be very technical. It can really go into the depth of what the spinal anatomy is. So it's always a great idea just to do a refresher and do a review on anatomy and the disease processes. Then we'll actually start to dig into the spinal arthrodesis procedures themselves. And you can open up your TruCode and I'll go through all the different categories of the arthrodesis procedures that they have within CPT, or of course you can follow within another encoder or your book. Then the last 2 sections, we will actually go through some real life op reports, some case studies, and that is 2 sections. The first section will go over a cervical and a thoracic. And then the second part will go over a lumbar and a spinal deformity case study. At the end, we have a lot to go over. If we run out of time and we don't get to the questions, like Sharon mentioned, please still continue to submit your questions. I'm happy to submit a written version of the Q&A that will be sent to everyone. If you happen to remember a question after the timeline, feel free to reach out to me on LinkedIn. I love connecting with people and answering questions that way as well. So let's get it started. We're going to talk about the spinal anatomy and the disease processes first. And we're going to start with the very basics, and that's the anatomy of the spine. So as you can see here, the spine is divided into really 5 different sections. The top there is going to be your cervical section, and that will be denoted in your op notes as C for cervical 1 through 7. And then the next portion is going to be T1 through T12, which is going to be your thoracic. And then lumbar which is L1 through L5, sacral, which is actually S1 to S5, and then your coccyx. So let's take a look at an individual vertebra, and like I said, this may be a review, but a lot of this terminology you will find within the op notes. So you really need to know the ins and outs of the individual vertebra and what the surgeon is actually performing. So if you look on the left there, that is the top view, the superior view of an individual vertebra. If you look at the bottom, that's the anterior or the front portion of the vertebra. And then the top there is the posterior or the back portion of the vertebra. If you take your hand right now as I'm talking and rub along the back of your spine, you'll feel a bunch of bumps back there. That is going to be your spinous processes. And those are along the back or the posterior portion of your vertebra. And that is going to be that top part there on the left, that's the spinous process. You also see a lot in documentation, you see the word lamina, which is kind of like the roof of your vertebrae. And then you will also see on both of the diagrams, on the left and the right, you will also see the pedicles, which the spinal nerve actually goes underneath the pedicle, as you can see on the right-hand side. You will see the word laminectomy a lot within documentation for spinal procedures, which is really the removal of that roof of the vertebrae. And you will see a lot of descriptions about pedicles and pedicle screws as well. And I also wanted to point out just on the right-hand side, the facet joints as well. That is a terminology you will see a lot as well within the op notes about facetectomies and stuff like that. The discs, the intervertebral discs, are in between each of the vertebrae. And those are really your shock absorbers in between each of the vertebrae. And the yellow on the left-hand side, of course, is your spinal cord. And you can see the same spinal cord on the right as well. Now let's talk about some diagnoses. Why would someone have an arthrodesis or a spinal fusion to begin with? And a big category that you will see for this is the category of disc disorders. And that could be degenerative disc disease, which is the general wear and tear of a disc. And that can cause chronic pain. And a lot of what we're going to be talking about here is really dealing with pain. And a lot of the patients will go through alternatives prior to surgery. They may try physical therapy, they may try injections, and really the patients will turn to surgery as a last resort to assist with the pain. Spinal disc herniation, you may have heard this as a slip disc, and that really is a tear in the disc. And I have a picture here on the right-hand side. On the top is a typical disc. On the bottom is a herniation. And you see on the right there really is that tear that is pushing against a nerve that would, of course, cause the patient some pain there. What other diagnoses would we see? Spinal stenosis is a big one, which is an abnormal narrowing of the spinal cord. And that really results in pressure on the spinal cord or the nerves. And you will see that symptoms typically will gradually have an onset, and they can improve for the patient if they're bending forward, because if you think about it, it really relieves that pressure. And on the right-hand side, there is a great picture of some spinal stenosis. Then we have our favorite word, spondylolisthesis, which is a spinal condition, and it really happens more on the lower vertebrae, where one of the vertebrae slips forward onto the bone directly beneath it, and of course it's very painful as well. You can have fractures, and that can be due to some kind of trauma or some kind of bone disease. And then you could also have a tumor that you need to excise as well. Then you also have some other diagnoses that could be needed for arthrodesis that we consider spinal deformities. And those two diagnoses are scoliosis and kyphosis. Scoliosis is a medical condition when a person's spine has a sideways curve, and the curve is either an S or a C shape, and it's over 3 dimensions. And the picture I have on the right here is an example of scoliosis. Kyphosis, on the other hand, is more of an exaggerated forward curve. So what are we doing exactly during a spinal fusion? Well, we are permanently joining together 2 or more bones in the spine so that there is no movement between them anymore. So really the goal with these spinal fusions is to really hinder that movement, permanently join together 2 bones, and really it's to help with that pain level that a lot of the patients are experiencing. There are many types of spinal fusions, and we'll talk about that more a little bit later, but each technique involves using bone grafts, and we'll talk about this more in depth as well. But that could include a bone graft from the patient, a donor, and or synthetic substitutes. And they use this bone graft to really heal the bones together and permanently fuse them. Additionally, hardware will also be used to keep those bones in place while the graft fuses the 2 vertebrae together. And I have a picture on the right-hand side just as an example of a device that would be used to hold those bones in place while the grafts were healing. And the example I used was, it just so happened to be a Harrington rod. You could also use an interbody fusion, where we are fusing 2 bones in the body where the disc is present between the vertebrae. So as the term kind of associates with, interbody is between the 2 bodies. And often you will use a device like a cage in this instance. And again, we'll go over this a little bit more in depth later. So now let's talk about some approaches, and we will also talk about later how it's very important to identify the approach, to select the appropriate code when you are coding these. So you can have an approach from the anterior or from the front. An example of that would be an anterior lumbar interbody fusion or an ALIF. So if you've seen documentation, it just says ALIF. That is what they're talking about. It's in the anterior coming from the approach of the front. You could also come from the back, which is posterior. An example of that would be a posterior lumbar interbody fusion or a PLIF. You could come from a transforaminal approach, which is posterior, you enter the patient, and then you actually go around to the side to get to the spine. An example of that would be a transforaminal lateral interbody fusion. From the side, or lateral, is the last approach that we want to bring out, and that is truly coming from the side of the patient. And 2 examples of that would be a direct lateral interbody fusion, or DLIF, and or an extreme interbody fusion, or an XLIF. So going back to the bone graft for spinal fusion, like I mentioned before, there are a few options when it comes for bone grafts. And again, the surgeons use this to pack the area that they're fusing to really help those bones heal together to prevent that movement that is causing the patient pain. So the three options that we currently have are from the patient, which you will see in the documentation coined autograft. You could have from another patient, which is called allograft, or you could have a synthetic or artificial, some kind of bone graft as well. And from the picture I have on the right, this is an example of an autograft where they took a bone graft from the patient. They actually took the bone graft from the patient's hip and were able to utilize that for grafting for the spinal fusion. Lastly, for this section, I just wanted to show a couple examples of what you may see in terms of devices. You may see fixation devices, which could include rods, screws, and plates. And that really stabilizes the bone while it heals and grows. And this is just a picture of some screws for spinal fusion. On the right-hand side, the other kind of device we could see is, especially if you're doing an interbody fusion, where you're taking out part of that disc. On the right-hand side, I have an example of a fusion cage, and you can see it goes into that space. So perhaps the surgeon took out part of the disc there and then packed it with some bone graft. It also has an example of a pedicle screw. When we were talking about the anatomy of the vertebrae, we talked about the pedicle, and that's where that pedicle screw goes. So like I said, this is the end of the first section. We'll move right on to the second section, where we will talk about the actual spinal arthrodesis procedures. We'll talk about the CPT codes and some of the guidelines. So if you want to have your TruCode, your encoder, or your CPT book, that would be helpful, but it's not mandatory, so don't worry if you don't have it. So what is an arthrodesis or a spinal fusion? And we went over this a little bit earlier, but it's really a surgery to permanently join together two or more bones in the spine, so there is no movement between them. And the AAOS definition also says that if you remove the cartilage of any joint to encourage bones of that joint to fuse or grow together, that is considered a joint fusion. I did want to stop right here and just also mention, especially as we get into some of the case studies, this area of CPT, I think it's a misconception sometimes that CPT is a standalone thing that has nothing to do with diagnosis. Occasionally it does have a little bit to do with diagnosis, and you will see a little bit later, some of the CPT descriptions do have to do with diagnoses. So just keep that in mind as we kind of go through this, that the CPT coding for spinal fusions can definitely be affected by diagnoses. So a question I get a lot is, hey Vanessa, I'm coding the spinal fusion and I just get totally confused about what is able to be coded separately in addition to my actual arthrodesis procedure. And what I often say is a lot of things are actually able to be coded separately. So we're going to go through that first, and then we'll go through the categories according to your CPT book. So the first thing that's able to be coded separately, and we've talked about it a lot already, is your bone graft procedures. And that on the left-hand side is just a little snippet from TruCode. The bone grafts for spinal surgery are generally within the category of 20930 and 20938. And those are going to be add-on codes. And if you have more than one type, you code for each type only once per each operative session. And as we get into the case studies, that will make a little bit more sense. But as an example, let's say I have a spinal surgery and the surgeon used both allograft and autograft. What would I code? You could code both, but you would only code once each. So if the surgeon happened to do multiple vertebrae with autograft, that doesn't mean that you can code the 20936 multiple times. And you can always look at the CPT Assistant from April 2012 for more information on that. And then I also just wanted to mention there is a specific code for bone marrow aspiration for bone grafting for spinal surgery, and that is code 20939. Now, what else could be coded separately? Another item that could be coded separately is your spinal instrumentation. And spinal instrumentation, and you will see this a lot within your op notes and your documentation, is broken down into non-segmental and segmental. On the left-hand side here, and one of the reasons why I love TruCode is their awesome pictures. So I took one of the pictures of a non-segmental spinal instrumentation here on the left-hand side. And as you can see, there is fixation all the way at the top where it says proximal hook, and all the way at the bottom where it says distal hook. And that is what makes it non-segmental. And the definition of non-segmental is that there is only fixation on each end of the construct and nowhere in between. And it just so happens that it is always posterior, and it can span several segments. And I've also added a CPT Assistant if you want more information on that particular code. So we have non-segmental, which only has fixation on the top and the bottom. What do we think segmental is? Oh, you got it. There is more fixation in between there. And again, this is a wonderful picture from TruCode. And it shows that there are many different fixations here, all the way at the top, all the way at the bottom, and a few places in between. So segmental instrumentation can be posterior, and there is a set of codes for that, 22842 through 44. And then it can also be anterior, which is another span of codes, 22845 to 22847. Now let's talk about, before we continue on with what else is coded separately, I just want to take a moment to talk about the fun world of interspaces versus segments versus levels. And unfortunately, CPT did not talk to Vanessa before they put in their terminology into the CPT verbiage. But you have to be very careful when you're coding spinal fusions due to these descriptions and how they go back and forth in their descriptions between these terminologies. And I'm sure there is reasoning behind it and where the actual part of the surgery is. But as a coder, it's one of the things I always like to point out, especially if you're going fast and you're trying to meet production, really take a second and read through the entire description to make sure that you are grabbing the correct code and you are adding the correct amount of add-on codes per the amount of vertebrae that your surgeon performed. So first is the word interspace. So an interspace is exactly like it sounds. It's the space between two of the adjacent vertebral bodies. So that's going to be where your disc is. So think the space between. Next is a segment. And a segment is a single complete vertebral bone with its associated processes and laminae. So let's take an example of a fusion between L3 and L5. So if my CPT description states two interspaces, if my CPT description states interspace, I gave you the answer already, there's going to be two of them because we're counting the space between L3 and L4 and between L4 and L5. Now, if my CPT description states segments, that is going to be the actual vertebral body. So we're going to count L3, L4, and L5, and we get 3. So we'll go over that again as we go through the case studies, but I always like to point it out, as well as the word levels. You will see that a lot in spinal fusions. The word level actually means how many times two vertebrae were fused. So if I was fusing L3 through L5 and they were asking me how many levels there would also be 2, because I fused L3 and L4, which was 1, and I fused L4 and L5, which was 2. So that is one of the more confusing parts of the CPT language surrounding this area. So we will go over this again, don't worry. I just wanted to introduce it right now. Now let's go back to what is coded separately. Lastly, your interbody and intervertebral biomechanical devices can be coded separately. On the left-hand side, again, is a wonderful picture from TruCode. It's 22853, which is an add-on code where you can place a device into a removed part of the disc. 22854 is a device placed into a corpectomy, and corp means body, if you go back to your midterm days. So with a corpectomy, the surgeon removed part of the vertebral body, and 22854 is a device that can fill that space. Then you have 22859 as well. And one note I always like to make is that codes include the instrumentation necessary for anchoring the device. And this is a question we often get from surgeons, if their instrumentation when it comes to these devices is included. Yes, device fixation anchoring the actual device is included. If there's any other posterior or anterior instrumentation to stabilize the actual spine, so think about keeping the device in place versus keeping the spine in place. You can code that additionally. There's some great information in the NCCI actual manual, the PDF manual that you download from the website. There's great information there if you need to back that up. And there's also information, CPT Assistant of March 2017. Now, if you want to open up your TruCode, your encoder, or your CPT book to the Arthrodesis section, let's walk through all of the different categories that CPT has categorized, and they have categorized it based on the approach. So the first group of codes that we're going to come across in CPT is the approach for lateral extracavity. And there are going to be 3 codes there. It's a pretty simple section. You're going to have a code for thoracic, lumbar, and then you will have an add-on code for each additional segment, thoracic or lumbar. So if you have 2 interspaces in the lumbar section, you could code 1 for the lumbar and 1 add-on code. And just as always a reminder, I will say this over and over again, you always want to read the entire description. This particular code is to prepare the interspace. Next is the arthrodesis for anterior or anterior-lateral approach. And this group of codes, you have a specific code for C1 to C2. You do have a special code for C2 that includes decompression, and that is an example for when diagnosis can come into play, because it also has its own add-on code. Then you have a separate code 22554 that is also for cervical below C2, and that is for a reason other than for decompression. So they are not doing the spinal fusion for a diagnosis of compression at all. So that would be 22554. And then you also have remember this is grouped by approach. So you have 1 for thoracic, 1 for lumbar, and then you also have an add-on code for all those 3 codes. The next grouping that you will see within CPT is going to be posterior or posterolateral. And you'll see here that there is a code 22590 for very, very high at craniocervical. There's one for C1, C2, there's one for below C2, there's one for thoracic, and one for lumbar. There is a special code for posterior interbody technique, which includes laminectomy and or discectomy, other than for decompression. So again, diagnosis can come into play. And then lastly, there is one combined posterior or posterolateral with posterior interbody technique. And again, it includes laminectomy and or discectomy. So again, a lot of how it's grouped is by that approach. So as we go through these case studies, identifying the approach becomes very important. That's kind of your first step into coding these appropriately. And then these are the add-on codes for those previous slides, and it really depends which parent code is used for you to identify the correct add-on code. Now, there is a special category for arthrodesis procedures for spinal deformity. So again, diagnosis does come into play with those. If you do have a diagnosis of scoliosis or kyphosis, for example, which is considered a spinal deformity, it would be within the 22800 to 22819 category, and I have a snippet there on the left from TruCode. And just like our other arthrodesis procedures, bone grafting and instrumentation is coded separately. And it's based on the approach, just like our other arthrodesis codes, and the number of segments. So posterior is going to be within the 22800 to 22804 range. And anterior would be the 22808 to 22812 range. And later we will go through a case study of one of those with spinal deformities. Lastly, I just wanted to touch upon briefly, this presentation is certainly not focused on professional fee billing, but I did want to mention about the modifiers for professional fee billing. Modifier 62 is a modifier for co-surgeons. A lot of these procedures can require 2 surgeons, so that modifier could come into play, but just take note that modifier 62 is not appended to bone graft or instrumentation codes. Also, I wanted to mention multiple procedures. What I think is one of the most confusing modifiers for the pro fee side. When arthrodesis is performed in addition to another procedure, 51 can be added, so just keep that in mind. And also just keep in mind that per definition of the multiple procedure modifier, modifier 51 does not apply to add-on codes. So just a little bit about modifiers in that section. Now let's get into our case studies and really start to code some of that. Now that we have our basics down, how do we get started with these spinal fusions and how do we start coding them accurately? Well, I recommend breaking it down into questions, and you might be able to guess my first 2 questions that I often suggest starting with. And the first one is, what part of the spine is involved? And the second is, what is the approach? With those 2 questions answered, you can really find the right starting point in your section of CPT that you're looking at. So what part of the spine was involved? Was it cervical, thoracic, lumbar, sacral, some kind of combination? And then what was the approach? Was it anterior? Was it posterior? Was it lateral extracavity? And then we always want to identify the diagnosis. What was the specific procedures performed and why were they performed? Was there spinal stenosis? Was there a disc disorder, a spinal deformity? Because now we know that would take us to a different set of codes. Was there a discectomy performed, an arthrodesis, a decompression, a corpectomy, or some kind of combination? So once you identify those, you can really start to narrow down the correct CPT code. And then for additional codes that you would want to add, you definitely want to identify the type of instrumentation. Are we talking about non-segmental or segmental? And if it's segmental, are we talking about posterior or anterior? And then additionally, you also want to identify the type of bone grafts. Are we talking about autograft, allograft, synthetic, or are we talking about bone marrow? So let's start. I'm not going to read every single word within these case studies. Feel free to do that at the end of this if you really want to know a little bit more about the details of what you might see in these op notes. But this is a patient who was having a cervical fusion due to C2-3 dynamic instability and worsening neck pain, and the postoperative diagnoses were the same. So the procedure's performed, and it's always a really good double check, especially with these particular spinal fusions. You can have a lot of CPT codes, so I always like to match the CPT codes back to what the surgeon lists as procedures performed, just to do a double check that you didn't miss any. So the first performed was a C2 to C4 posterior cervical segmental arthrodesis. So we already have a lot of great information there. C2 to C4 posterior cervical segmental arthrodesis. So just kind of keep that in mind. Posterior cervical instrumentation with C2 par screws as well as C3 and C4 lateral mass screws using the Stryker Oasis system. Use of allograft, use of autograft, use of bone marrow aspiration from the hip, like we talked about before, and then the use and interpretation of neurophysiologic monitoring. So moving on, this was just a 59-year-old female, worsening neck pain. They did try alternatives prior to surgery. The patient acknowledged the risks. The patient was brought to the operating room. Neurophysiologic monitoring was set up, and she was then flipped to the prone position. So the patient was flipped prone, face down. So that kind of gives us another indication of what kind of approach the surgeon was using. Dissection continued in the midline down to the C2 to C4 spinous processes. And the C2 to C4 was exposed. Then they started the par screws in C2. Pilot holes were made. Screw trajectories were drilled, and they were tapped, and a ball tip probe confirmed no breaches. And then they note that the patient had particularly small lateral masses, and that necessitated extending the fusion down to C4. So maybe prior to this case, they hadn't planned to go down to C4, so that's important to note. They did some pilot holes bilaterally in C3 and C4. The screws were placed bilaterally at C3 and on the left at C4. Titanium alloy rods were placed. Then they talk about the stab incision for the bone marrow, for the bone graft. They talk about the allograft. They talk about bone that was morselized or chopped up from the C2 or C4 that was removed. They talk more about the allograft and the autograft, and that was packed laterally adjacent to the rod to help that rod heal. And then the patient was closed, and the patient was extubated and transported to the recovery room. So let's go back to our questions. Let's start with what part of the spine was involved? Cervical. What was the approach? Posterior. And what was the specific procedure and what was performed and for what reason? This is a cervical arthrodesis for worsening neck pain. So we always want to note the diagnosis as well, just in case. What type of instrumentation? This was segmental, and it was posterior. And the bone grafts that were used, we had a lot in this one. We had local bone grafts, we had aspiration, and we had allograft. So let's start coding. And like I said, I like to list it in the way the surgeon does. So sometimes if the surgeon kind of does it in a way that a coder might not, that's okay. You can kind of work backwards with them. So number one was the first procedure that the provider placed for us to look at. So we had C2 to C4 posterior cervical segmental arthrodesis. And I put a little snippet there of what it would look like within TruCode. So if you put there in the search feature for TruCode, if you put arthrodesis, posterior cervical, if that's all you put, it would bring you to this section. And of course, like I mentioned previously, you always, when you are coding spinal procedures, you always want to read the entire description because it can get confusing in the terminology, and they do flip back and forth between the words level and the words interspace and the words segment. So here, it took me to the code 22600. And that is the posterior fusion of a single level below C2 segment C2 to C3. And then you would add an additional level, that add-on code at the bottom of my snippet from TruCode. You would also add that add-on code 22614. Now you may be saying to yourself, Vanessa, that doesn't make any sense. There's 3 vertebrae. Why did I only code 2 codes? Well, look again at the description. It says level. And when we're talking about fusions, a level is considered 2 vertebrae that have been fused together. So one level of fusion is going to be C2, C3, and the second level of fusion is going to be C3, C4. So always make sure you look at the full description. Additionally, you can code that posterior segmental instrumentation. And now look at the description for that code. That code says segments. So when you're counting the segments and choosing the appropriate code, make sure that you are counting the correct number of segments, which is your actual vertebrae. So that would be code 22842. And then for the allograft, autograft, and bone marrow, you would code additionally 20930, 20936, and 20939, and you would add the RT for laterality. Whew, we made it through the very first case. Let's move on to the thoracic case. And this one is a little bit different because this involves a metastatic epidural adenocarcinoma. So we're going to be removing a tumor while we are doing the spinal fusion. So the procedures performed was a spinal neuronavigation with a stealth Medtronic neuronavigation. Spinal instrumentation included pedicle screws and rods bilaterally, and that was at the levels of T7, 8, 9, and 10. And the surgeon was very nice and put what the total of levels would be for that instrumentation. There was a laminectomy for resection of the spinal epidural tumor, and that was at T7, 8, 9, and 10. And then there was a bilateral posterior lateral arthrodesis, and that was at 3 levels, T7, 8, T8, 9, and T9, 10. So let's look at this op note a little bit more in depth. And like I said, I'm not going to read the entire thing, but the patient was brought into the operating room. The surgeon opened up the patient and proceeded to perform a laminectomy at T7, 8, 9, and 10 for excision of the tumor. The tumor was removed. Then they proceeded to place bilateral pedicle screws at T7, bilateral at T8, right-sided pedicle screw at T9, bilateral pedicle screw at T10, and this was placed under neuronavigation. And to cement everything in place, they used allograft. Drains were placed, family was updated, patient was extubated, and that was the end of that one. So let's start to ask our question. What part of the spine was involved? And that would be the thoracic, T7 to 10. What was the approach? Posterolateral. So that surgeon actually went in through the back and around the side. What specific procedures were performed and for what reason? Again, it's always important to write down your diagnosis and what the reason was for these procedures. So this was a thoracic arthrodesis and the removal of that adenocarcinoma. What type of instrumentation? Again, this one was segmental and posterior. There was an allograft and neuronavigation. So what would we code? We can code additionally that stealth Medtronic neuronavigation. There is an add-on code for that, 61783. Again, we could additionally code, like we talked about previously, the posterior segmental instrumentation, and I'm going to count the vertebral segments, which is the actual amount of vertebrae. So I have 4 segments, so I can code that 3 to 6 vertebral segment code. Now, the laminectomy for the excision of the extradural thoracic intraspinal neoplasm can be coded separately in this scenario because it was for a different reason other than the spinal fusion. So you can code additionally the 63276. Now let's get, like I said, the surgeon in the scenario kind of did it backwards from how a coder might think, but I always like to follow the surgeon's listing of the procedures performed just so I can double check that I have every single code that surgeon deserves. So lastly, the surgeon performed a bilateral posterolateral arthrodesis, and that was at a total of 3 levels. So again, when we talk about levels, we're talking about the amount of time 2 vertebrae met to be fused. So if you put into your TruCode arthrodesis, posterolateral, thoracic, you will get the code 22610, and that will include a single level. So we are going to need an additional 2 add-on codes for that section. And in that section, the add-on code for each additional vertebral segment is 22614, and you would want to code that 2 times. So I have my 3 levels covered there. And lastly, you can code your allograft, your 20930. And that's the end of that section. I am going to go ahead and skip the lumbar case study, but please let me know if you have absolutely any questions with that because I would like to move forward. It involves an interbody device, and I have how you would code it. So please feel free to reach out on any questions on that one because I do want to get to the spinal fusion for a spinal deformity. The spinal fusion for spinal deformity, like I mentioned, is a totally separate category, and it really is dependent on the diagnosis. So this is a patient, a 12-year-old female, who has idiopathic adolescent scoliosis, and she is coming in for a posterior spinal fusion, T5 to T12. So T5 was identified proximally and T12 was identified distally. Then they confirmed the track for the pedicle. They placed the pedicle screw. Each screw was performed in a similar fashion. 2 pedicle screws at T10, 11, and 12. 1 at T9 on the left, 1 right at T8, 1 left at T7, 1 right at T6. And then they placed hooks, and then they started placing the rods. Then they started using some manual force there to try to correct the scoliosis. And then they attached the right-sided rod. They placed allograft bone in and around the hardware to additionally aid in the fusion. They did some films. The patient was extubated and transferred back to the recovery room. So let's do our questions again. We always want to start with that. What part of the spine was involved? Thoracic, T5 to T12. The approach was posterior. And what was the specific reason? And again, we always want to note that it was done for scoliosis and one of the spinal deformities. What type of instrumentation was used? One of the specialized posterior segmental fusion sets for scoliosis was utilized, so it was posterior and segmental. And they also used allograft. So how would you code this? And if you put into your TruCode, I have a little snippet below. If you put into your TruCode arthrodesis, posterior spinal deformity, or even if you put arthrodesis, posterior scoliosis, it'll come up with the code 22800. Now for this particular scenario, you would code the 22802 because if you count the segments, look all the way on the right there, read the full description. They're talking about segments. If you count the actual segments from T5 to T12, you're going to choose the 7 to 12 vertebral segments code. Then you would add the posterior segmental instrumentation, which would be the same 7 to 12 vertebral segments. And then you would add additionally the allograft code for 20930. So I hope you enjoyed this presentation, and I hope you enjoyed the case studies and hopefully learned a little bit more about spinal fusions and CPT coding. Again, we are, yes, HIM Consulting, and our services are up on the screen. We do everything from denials remediation to coding, auditing, mentoring, consulting, and like I mentioned, we have our own education portal where you can actually log in and do some online webinars and some refresh with yes, like we did today. And you can always get in touch with us. You can always get in touch with me via LinkedIn. And we are currently offering a 20% off discount code for any Yes HIM education course. And the discount code is Independence20. It's up on the screen, all one word. And this offer is valid up until July 31st of this year. So come check us out if you're interested in some more education. And I want to thank TruCode so much again and send it back to Sharon and Karen.
Thank you so much, Vanessa. That was really excellent, and tons of questions I can see that came in. So we will be sure to send them over to Vanessa, and then we'll distribute those to everybody on this webinar. Was there another slide, Vanessa, that had a URL, or is that the last one?
This is the last one.
That's the last one. Okay. So for those on the live webinar right now, as I said at the beginning, in order to receive your CEU, you'll receive an email tomorrow morning, and that will have a link to the evaluation. Once you submit the evaluation, you can download your CEU certificate and reach out to me if you have any issues with that. For those people that are watching this as an on-demand webinar or watching this recording, The directions for getting your CEU is to visit www.trucode.com/spinal-fusion-CPT. And if you have any questions, you can reach out to me at cbyron@trucode.com. So once again, thank you, everybody. Thank you, YES team, for an awesome webinar, and we'll see you all on another TruCode webinar. Take care, everyone.